Concept Fertility Center. So first of all, thank you everybody to join us today, and hopefully you would enjoy the previous session. So what I am going to discuss today, I am going to discuss a very common topic, that is polycystic ovarian syndrome. So apart from that, I would like to discuss today what are the challenges as a fertility specialist we are facing as in dealing with the PCO patient. So before starting my presentation, I would like to tell you what are the references from where I have made this presentation. So I have made this presentation from the ASHRAE guidelines, that are the authentic guidelines, and everyone, the whole world is actually following for the fertility practice. So what is polycystic ovarian syndrome? We know very well this is the most common endocrine disorder in the reproductive age group that can badly affect the female appearance, fertility, and also can affect her self-esteem and may have some long-term implications that we will discuss later. So what is the incidence of PCO? Globally, its incidence is 2 to 25% of the cases, but unfortunately in Asian population it is increased dramatically. And that shows the role of genetic actually and the environmental factor in PCO. So now what is the diagnostic criteria of the PCO? We know very well that is the Rotterdam criteria that we are following for the many years. And what is this Rotterdam criteria? It shows that 2 out of the 3 features should be present to diagnose the PCO. And what are that actually features? These are oligoanovulation, hyperandrogenism. The third one is polycystic ovarian morphology that I am going to discuss later. So when 2 out of the 3 things are present, we call that this is a case of polycystic ovarian syndrome. Now, in this slide, you may find something new because these are the recommendations of the ASHRAE guideline, and what they show, they recommend that we need to prefer the DBS scan for diagnosis of the PCO. And on that scan, number of the follicles per ovary should be more than 20. Am I clear so far? Anyone want to know that previously that is actually the 12 follicles. Now the guidelines said that there should be 20 follicles per ovary to diagnose the case of the PCO. That is different from previous knowledge that we have. Am I right? Anyone want to answer that to make it interactive, because I can understand that everyone is exhausted right now, and so please just a little bit concentration is required, and we can make it interactive, and you will get the benefit. I will just trust on me. Okay. So what I am discussing, this is a very, very important slide, and this is the criteria how to diagnose the PCO on ultrasound. So it is changed. Previously 12 follicles are criteria, but now number of the follicles per ovary should be more than 20. And also reassure that there should be no corpus luteum, no cyst or no abdominal follicle on the scan. ASHRAE guidelines also recommend, if you would like to go for the previous technology, please go for the volume of the ovary. That should be more than 10 ml. Okay, am I clear? These are the 2 very important recommendations by the ASHRAE. The third thing that is very, very sometimes confusing for the gynecologist, when we see the ultrasound of the young girls and it is said that this is the patient of the PCO. So in order to reduce that confusion, the ASHRAE guidelines recommend that don't go for the ultrasound to diagnose the PCO at least 8 years after the menarche. Because in that group, what happened that the multiple follicle ovaries are already there. So there is no use and we cannot diagnose that as a PCO. Okay? So this is important and I think it will be useful for all of you. So now now what next after the ultrasound? We used to do some hormonal tests, and in that one of the most important is the follicle stimulating hormone. It is normal in the PCO patient, and MH, that is the luteinizing hormone and testosterone, these may be normal or may be elevated. And I mark it red. Why? Because when the level of the NH and also the testosterone is increased in our patient, that patients are actually challenging for us regarding the stimulation of the ovary. Alright? Apart from that, we used to go for the thyroid and prolactin function also. And because with PCO, there is the evidence shows that there is a little bit change in thyroid and the prolactin levels. And also, we prefer to go to assess the vitamin D because in Asian population it is already low. And also with the PCO, we have seen that the patient has reduced vitamin D. Also, we are Asians, and in that we have the phenotype of the polycystic ovary that is metabolic. So we should go for that screening of the diabetes, but we not go for all the patients, but we always go for the HbA1c in order to see the sugar levels of the last 3 months. Also, we used to do in our practice the insulin levels, and if we will find that the insulin levels are high, what we do, we treat that also before the treatment of the infertility. So one last hormone is, and that is anti-molarin hormone, that is actually produced by the preantral follicles, and it is usually raised in the PCO, but it can be normal. But if it is raised, always the infertility specialist always alert, and it is the predictor of the ovarian hyperstimulation syndrome, and we will consider very seriously. And its amount is like 5 nanogram per ml, so it should not be more than that. And if it is, we are very focused for the patient and we do the many things for even the titration dose, low dose, we will start to reduce the chances of the OHSS. So in this slide, I have explained what are the features of the PCO. We know very well it may cause the irregular periods and no periods at all, and it may cause the acne, hirsutism, and also the alopecia. It may cause the polycystic ovaries. One of the most important association with the PCO is with the opacity in especially Asian. So one important thing that I would like to tell at this point, that all the features of the PCO are not present in a single person. It may patient have 1 or 2 features, and these features can vary according to the age. So now, what are the long-term implications with the PCO? The most important is the infertility. That is actually the key issue that I am going to discuss today. Other are the anxiety and depression. If woman is with negative body image, with fear of not getting the baby, there is a chance that patient can go with the depression, because this is a long life condition and patient can have the mental health problem because of that. Other than this, it may cause a metabolic problem like diabetes and this is a cardiovascular problem because of the dyslipidemia. And the last thing, that is the endometrial cancer, can be increased if patient not menstruating at least 4 times per year. So we need to always think on the long-term implications of the PCO. Now, what is the pathophysiology? In this slide, I will try my best to explain you what is going on with this PCO, especially in Asian population. Actually, what happened in us, abdominal opacity, genetic predisposition, and the lifestyle, what they do, they increase the insulin resistance in our body. And what insulin resistance, we know very well, actually the insulin is a hormone that is required for the utilization of the glucose. When the body will not get the response, what happens, the glucose in our body is increased markedly. That directly increase the adipose tissue and may cause the opacity. So it may directly cause this obesity. One more thing, the insulin resistance doing in our body, it's changing actually this hypothalamic pituitary ovarian axis. That actually what it do, it change the LH-FSH ratio that result failure of the follicular growth and then an ovulation and infertility happen. Third thing that insulin resistance is doing in our body is decrease the hepatic sex hormone binding protein and that result the increase the testosterone level. So the bottom line of this slide is there are the two things happening. One is the insulin resistance and second is increase the testosterone that is actually causing all the features of PCO patient. So this is the pie chart that I especially want to show you. It shows the percentage of the patient we are dealing in infertility center with the female infertility. And in that, the major part is the ovulatory disorder. And in this ovulatory disorder, the 85% of the patients are of PCO. It means we are dealing with the PCO patient very frequently, even daily. So how are we dealing PCO patient in infertility center? We always follow the multidisciplinary approach and we take the help from the endocrinologist, dermatologist, dietitian and psychiatrist when needed. And when the patient comes to us, what we used to do, we try to optimize her health as much as possible. We started the folic acid 400 micrograms daily, and if BMI is more than 30, we used to give according to the recommendation that is 5 mg daily in order to reduce the neural tube defect in the baby. Then we always go for the semen analysis and also the tubal patency test in order to rule out any other cause. So this is the treatment of the infertility and this shows the different lines of the treatment. In that, what we used to do with the PCO patient, we always try non-pharmacological treatment, that is lifestyle modification, and Dr. Sana explained very well about that. If it will not work, then we go for the first line pharmacological management for the infertility. That is actually different medicines are available. One is the letrozole, other is the chloromethane citrate, third is the combination of that and the metformin. So the promising result in the live birth we are getting from the letrozole and it is proved by the ASHRAE guideline and also many randomized controlled trials also show that. It is better than the chloromethane in this sense that it will not cause any anti-estrogen effect on the endometrium of the uterus. That Dr. Sabda explained very well that the endometrium should be healthy. So letrozole is better drug as compared to the chloromethane. When these ovulation medicine will not work, then we can go for the second line treatment that are the injections of the gonadotropin. But gonadotropin should be given in the fertility center because there is more chance of the ovarian hyperstimulation syndrome in PCO patient. And also, it is actually there are very frequently scans are needed for the monitoring, and for the monitoring, the specialized person would be needed for the TBS. Second line is the laparoscopic ovarian surgery that we usually not go for only the purpose of the ovulation induction. We prefer it when we are doing the laparoscopy for any other reason. Then we used to go for the laparoscopic ovarian surgery also, and I will discuss what is the mechanism behind that in a while. So as a last resort, third line is the IVF treatment, and especially we can start the IVF early if there is any other reason of infertility is there. For example, semen analysis problem or any tubal blockage is there. So what are the treatment? We have discussed the first line is the lifestyle intervention. Dr. Meena explained it, so I will not take more time. Just I would like to highlight what are the interventions we can do. We can provide the dietary interventions. exercise intervention, and also weight management. So what we will do in the diet intervention, there is no any specific diet that is evidence to improve the PCO. Diet should be better and that is actually suitable and patient is compatible with that, but it should have the complex carbohydrate as compared to the refined one. Fruits, vegetables are very important part of the diet and patients should take that. Exercise intervention, the evidence shows that if you would like to maintain the weight, you can offer the patient 30-minute brisk exercises. But if you would like to reduce the weight, you should go and advise for 60 to 90 minutes the brisk exercises to reduce the weight. Now the weight management, actually it is of two types. One is short-term weight loss. Second is the long-term weight loss. Short-term weight loss evidence doesn't show any improvement in the live birth, but long-term weight loss actually improves the live birth and also increases the chance of the IVF success. So what we used to do when the BMI is more than 40, we always encourage and we have the patient that is young, that has a time, so we always encourage to go for the bariatric surgeries that can very important for the long-term weight loss. So after the lifestyle modification, as we are Asian and in that we are in our we have the insulin resistance in our body. So they are the two main medicines that we can use for the improve the sensitization. What are that? One is the metformin. We know very well about metformin. But the problem with this metformin is nausea, vomiting, stomach upset. These are the side effects of this medicine. And what we can do for that? We can start with the low dose. That's evidence-based. We can start from the 500 milligram. Then in 1 to 2 weeks, we can increase the dose. On other side, we can use the extended release metformin that has less side effects. The third option is the inositol that we can use instead of the metformin. This inositol is actually giving the promising results even in our center, and they are the emerging evidence that are highlighting the importance of this formula that is inositol. And we have a different preparation that we are using. One is given biotic, iron folic, axolic. There are the different names are there, but in our center we are getting benefit of also from this, especially if women not want to take the metformin and women insulin levels are high. So this is a slide that showing how the letrozole is actually doing the function. It is aromatase inhibitor. It's blocking the androgen conversion into the androgen, this estrogen. And when the body has low estrogen, what the brain feels that we have less estrogen, so it stimulates the GnRH, this gonadotropin-releasing hormone, that indirectly improves the FSH-LH, and in result, ovarian follicular growth happens. So we will get the benefit by in this way by the letrozole. So when we need to stop the letrozole and we need to move to the second line, at least 6 cycle evidence shows that we should continue if we are getting the result that is ovulation. If not, then we can move to the second line earlier than 6 months. So the second line is the gonadotropin, and I have discussed that there is a strict monitoring, ultrasound, and also the titration dose is required for that, and it should be given in the infertility center. So that this is the second line, that is the ovarian drilling. I just want to highlight how it actually works. It actually ovarian drilling cause effect on the theca cell, and it prevents the production of the androgen by the theca cell, and that actually results in the follicle maturation at the end. So the last resort, that is the IVF and the third line, and careful monitoring is required for the multiple medicine we use during this IVF cycle, and there are the many challenges that we are facing when we will go the patient with IVF and PCO. So what are the challenges in the IVF in PCO patient? These are high responders, increase the risk of early or the late OHSS. Also, it increases the risk of the cycle cancellation because of OHSS stress, difficulty in titrating the dose of the gonadotropin we find, and also it is very important to know that this is not only the PCO is affecting the ovulation, it actually affecting the maturation of the egg also. So if even the patient is ovulating, patient can have the low infertility. And because of that, the reason is the poor egg quality is many times we have seen in our patient, we do our best, but the egg quality is not improved and the immature cells are retrieved on the egg makeup. So when the immature cell we find, what happened that the fertilization would be reduced and the poor quality embryo can be formed, and that actually causes the lower implantation and the less success rate of the IVF. So we all are dealing with these risk with the PCO, and we are dealing with these challenges and doing the best for the patient with PCO. So what are the best protocols for the IVF in PCOS patient? Considering the risk of ovarian hyperstimulation syndrome, there are the two protocols are recommended by the ASHA guideline. In all over the world, the most famous protocol is GnRH antagonist, in which we give the medicine with the gonadotropin, that is cyclotide, and then we will go for the all-freeze technique and we will go for the FET, frozen embryo transfer. In that case, we used to give the trigger, that is GnRH analog. The second protocol that we use for the PCO patient to avoid the risk of OHSS is long protocol with the gonadotropin analogs. GnRH analogs with the gonadotropin. And what it do, it is actually stabilize all of the previous follicle, and in this we have benefit of getting the more ovaries and more eggs with the mature follicle. So these are the two protocols that are used all over the world for the IVF patients with PCO. So I just want to tell you that what patient we are treating is actually patient with the negative body image, with the fear of not having a baby, and patient can have social, emotional issues. So what we need to do, first of all, we need to know the mental health of the patient, and for that we need to ask and we reassure in our fertility center and give her hope that she can get the baby. So I'm closing my presentation, ending my presentation with this take-home message. Our doctor's smile makes the patient happy. Holistic approach to deal the PCO patient with infertility is the key of the treatment, in my opinion. So thank you so much.